It's now 3 o'clock and we're taping now, so welcome all. Thank you very much for coming, and thank you to those who've dialed in. I want to start by welcoming Peter Axon, who's the interim CEO of the Integrated Care System, who I believe is online with us. Hi, Peter. And to thank Simon Whitehouse, who served on this board, and thank him for all his contributions over the years, and we wish him well for the future. Thank you. I have apologies from Dr. Rachel Gallagher, Dr. Paddy Hannigan, Roger Lees, and Rita Heseltine. It's down here that Simon Whitehouse is an apology, but actually Peter's in lieu of Simon now. Okay, thank you. Do we have any declarations of interest? I think I ought to declare a declaration in that the Air Aware piece, I'm both a resident of Cannock Chase and a district councillor in Cannock Chase. Unless anybody thinks otherwise, I don't think that should prevent me either from chairing or from contributing to the debate.
I should probably declare that I'm Chief Executive of Cannock Chase District Council.
You are. Thank you, Tim. Okay. Thank you. The minutes of the last meeting held on the 2nd of September 2021. Do I have any points of accuracy? No? Is everybody happy with them? Anything coming from those minutes that don't appear in the agenda? Happy for me to sign them off? In which case, I will, thank you. Before I go to any questions from the public, given this new variant, I would like to give Richard Harling, Dr. Richard Harling, an opportunity to update us. However, given the number of items on the agenda, I will not offer anybody questions about it. It's simply an update as to where we are. And if you do have any questions, then please email Richard and he will deal with them that way. Thank you.
Thank you, Chair. So overall, a number of cases of COVID in Staffordshire remains high. It has been decreasing over the last 7 days, but there's still a lot of it about, particularly in schools. Internationally, the Omicron variant is causing concern because it is a significant mutation of the virus, and the concerns are twofold. First of all, that it might prove more serious, and secondly, that it might evade some of the vaccines that have been delivered internationally. It is very new, and all of the data is at an early stage, so it is impossible to comment with confidence on either of those 2 points. I think the situation will become clearer over the next couple of weeks. In the meantime, the government has introduced some new rules. They are PCR testing for people returning from other countries, a requirement for everyone who is confirmed with this new variant to isolate for 10 days, irrespective of vaccine status, and a requirement for face coverings in shops and other indoor public spaces. Just encourage everyone to follow those new rules and generally just to take precautions to prevent the spread of infection, and more than ever to take up the opportunity for vaccination. That means 2 doses for everyone from 12 years upwards and a booster dose for all adults. The NHS is busy making sure that vaccine capacity is available, and again, just to encourage people to take that opportunity. Vaccination is the main way that we will resist the spread of illness caused by this new variant of the virus. Thank you, Chair.
Thank you, Richard. Are there any questions from the public? There don't appear to be any public, so there can't be any questions. Thank you. Item 2, the JSNA. Claire McIver. Claire, thank you.
Thank you. So hopefully this will be a relatively short item and should segue nicely into the next item around the Health and Wellbeing Board strategy. So really what I'm here today is to present the sort of final iteration of the JSNA, which has now been published on the Observatory website. So within the covering report, there was a link embedded within that on the second page. It is now live, so the board has received both the sort of summary headlines and the final version of the JSNA pack at the June and September meetings. Following that, comments and feedback have been incorporated into this final version. Some additional data metrics have been used, and we're now at the point where it's proposed that this is sort of signed off as the final version of the document. The web link, as I say, takes you to the front page, which has then got a number of different sort of sections behind that for more and more detail, really, depending on how far back you want to go. So there's an opportunity to look at the headlines and the key trends, and then there's sort of more detailed data sets behind that and some of the geographical hotspot mapping as well. So I think a much more user-friendly and useful version of the data. The intention is that it will be an iterative process anyway, so it can be updated through that live sort of web-based version, which I think again will be much more useful. So really it's just to sort of make the board aware of that, ask for agreement for this to be signed off, and if, once you've had a chance to look at the link, if you haven't already, if you do have any further feedback or anything that you spot as an error or something you need to be corrected, then obviously we can do that, but I think at some point we have to kind of agree to draw a line under the JSNA as a sort of piece of work, just because data is continually being updated. So I think at some point we have to say, right, that's it for this year, we'll publish this one. But as I say, that being said, we can develop and update that if necessary, if there's a significant update in any of the data sets within it.
Thank you, Claire. Julia.
Just a very brief comment from Hello, Chair. I've gone through the JSNA, and really it's very much now as to how we take this forward. As you know, we've had discussions about there are certain areas within the county, certain activities like smoking with pregnant women that seems to not be making much progress in certain areas. And I think this is a very useful document, a much easier to use format to be able to understand where we need to be targeting our efforts and seeing if we can make that real difference, because I think that's why we're all here, and that's why this valuable database is such a useful tool. Having said that, a little bit tongue-in-cheek, I've just tried to click on the link, and I've got the dreaded 404 page not found. So could I implore IT just to make sure that actually the link does work and people can access that report and the data behind it. Thank you.
I'll get Wendy to double check that, because I've got it open here, so it's definitely working and live. It must just be the link that was embedded within the covering report, so I'll get it recirculated with the right one.
Because as you know, I had trouble with the link as well.
Yeah.
Okay.
Thanks, Julie.
Any other comments? Thoughts? I think your point's well made, Julia, and it feeds quite well into the next item on the agenda. And therefore, I think we should move to that unless there's any other questions. The one thing I would ask, given the fact that this is an iterative document, it'd be worthwhile the board and indeed the chair of scrutiny being advised by email when there is a significant change to the JSNA throughout the year, so we can remain appraised of what's going on. Okay, thank you.
Yeah, certainly. I'll mention that to Wendy and Martin as well.
Thank you. Just before I go on, it does appear as if there's more apologies here. Simon Fogel from Health Watch, Carmel Warren from Staffordshire Fire and Rescue Service. Those two. So I think if that's the case, they should be added. Thank you. Item 3, the health and well-being strategy. Claire, over to you again. Thank you.
Thank you. I think Liam's just bringing up the presentation. Perfect. Shall I test this? Ooh. Always really impressed when that works. Right. Yes, so as I say, hopefully a nice segue from the JSNA. So as a result of reviewing the JSNA and a whole range of other bits of insight, feedback from board members, and the discussions that we've had at the last 2 or 3 meetings, I guess, what we've done is pulled together a draft strategy proposed for the next 5 years. There's a question mark by that date, just really because that's a question for the board. Obviously, there's always an opportunity to review and update within that time frame anyway, as we are doing now. So it's as fixed as we want it to be, I suppose. The title, again, proposed is Health is Everyone's Business, and really that's to reflect the focus of the strategy as a system-wide, sort of upstream approach focusing on prevention and the wider determinants of health, and a population health approach. So it's about how we think about health and well-being in the round, all the sort of causes of the causes, I guess, in terms of people's health and well-being and their lifestyle choices. So what I'll do is I've put into a slide deck today just the key headlines, really. So I've lifted the salient points from the strategy and some of the key discussion points for the board today. It's ready as a Word document. I just didn't feel that was probably particularly conducive to a good discussion to sort of go through that on the screen. So after the meeting, I'll get that circulated. It's intentionally quite brief, so I think 9 pages. I wanted to make sure it was readable, usable, reader-friendly, that people actually bother to get to the end of the document. So the brevity is intentional. Hopefully there's enough detail in there to capture the sort of the key points that people have fed back. Again, though, it is intended to be quite high level, so I think part of the discussion today needs to be about what happens next and how we translate that into some deliverable actions and some accountability around those actions. So there are some prompts that I'll sort of raise throughout the presentation, but I guess that's where the discussion needs to go next. So there's a very brief introduction within the strategy, just sort of half a page, which focuses on Staffordshire as a county, rich in variation. It talks about this being the strategic direction for prioritising and sort of how and where we take activity around improving health and well-being, refers to the insight that's gained through the JSNA and other sources, but also recognises the importance of personalisation and choice, so focusing on how we keep people independent and well as having support services and sort of care available as and when it's needed, and that those are tailored and targeted to specific audiences and cohorts of the population. And I think also I wanted to reference the fact that we would hope, I think, as a board, and this reflects a lot of the conversations we had with people, that it would build on and sort of further develop that collaborative approach that's been, I think, really successful over the past 18 months, where those organisational barriers have been, for the most part, dropped. And so I think that's a sort of a feature throughout the strategy as well. Then it just quickly moves on to a summary of health and well-being and some of the key assets work that was weaved into the JSNA. So these are some of the highlights, I guess, that have been lifted from the JSNA. So, an ageing and growing population, challenges at the start of children's lives, not least in relation to overweight and obesity, mental health, also a little bit later in terms of things like key stage 4 attainment, inequalities, I guess, being a prevailing issue throughout a lot of what we talk about, both in terms of health outcomes, but also people's access to services and even health and care information. Fuel poverty, not necessarily being dramatically above the national average when you look at the whole population, but again in pockets particularly bad, and it's that inequality again that's a feature and something I think needs to be a focus of the strategy. Poor mental health and well-being, including isolation and loneliness, health outcomes that are caused by health-related behaviours, so things like alcohol consumption and poor diet and things like that. And also just the pressure on services. So again, lots of feedback, anecdotal and through the data in terms of increased demand, but also those health conditions across the population, those long-term conditions that are prevalent that are causing that increased sort of pressure in terms of services. So I guess a question for the board at this point is, are these the right areas that we've identified? Have we missed anything? Does this feel like it reflects where we've got to in terms of the JSNA? So we can either answer them as I go, Johnny, or we could come back to them all at the end. I'm flexible really on how we do it.
With your agreement, I think we should take these now and have a discussion about that now. So I'll open it to the floor. What do you think?
I can always take silence as agreed. I mean, obviously there's opportunity for people to feedback afterwards once they've had a bit more time to digest this. But this, it shouldn't be a big surprise to anybody because it's a reflection of what they've seen in the JSNA anyway to date. So,
I don't think there's anything missing in my judgment. The issue is what we do with it and where do we go with it from here, which is clearly what you're saying, I think.
Yeah, so I'll move on to the next section.
Fine,
and we'll hopefully see a bit more of that. There we go. So this is just a summary paragraph, I guess, in terms of what the board's strategy is about. So about, again, promoting that collaborative approach, healthy environments, and drawing on existing strengths and assets wherever we can. It's about how we provide the conditions to support healthy choices, and also making sure we've got where we need it, that high quality and equitable support to keep people independent and well when they need it, but also about thinking health in all that we do. So that comes back to that health is everyone's business title at the beginning. And there's an ambition to reduce health inequity and inequality, and to increase healthy life expectancy for all, which is obviously a significant ambition, but we want the ambition to be ambitious, don't we, I guess? So I guess, again, in terms of this slide, it's a question about, does this overview and ambition meet your expectations? Is this the kind of thing you would expect to see? Does it reflect the feedback that you've given in terms of the strategy and what you would want to see within that? I'm getting some nods. I'll move on, okay.
Yes, as I think it was at the Overview Health and Scrutiny Committee earlier on this week, a question was asked as, who's responsible for the public's health? And I said, public health can do so much. We can provide the services and the framework, but at the end of the day, public health is owned by the public. And I think what we do need to ensure that in our enthusiasm for doing the best that we can with the resources that we have available, that we still stress that actually it's a partnership between ourselves and individuals. And it's, I don't really like the expression, but the strengths-based approach, which is actually encouraging people and motivating people to do as much for themselves as for us to help them do that. So, I understand and totally support where we're coming from, but I think it is important that people recognise the biggest gains that can be made are often by simple steps by us all. And I think we do need to keep that in mind. Otherwise, I think there is perhaps unrealistic expectation as to what we as public bodies can achieve in terms of improvements in public health. We've gone through the history of improved sanitation, water supply. I'm not sure where we are with fluoridation of water, and I'll probably get shot down with that. But those big public health advances, there are things we can do, and I think Air Aware is a scheme that raises that awareness about particularly the air quality outside schools, which is important. But I think, unfortunately, there's a sector of society that expects things to be done to them and for them instead of actually, increasing and improving that motivation and that self-empowerment, really, that actually as individuals we can make that difference. So totally support the way the strategy's going, but I think we ought to make sure that it needs to be that constant reminder to individuals that actually, you know, their motivation is that can be the difference between success and failure of improving the public's health. Thank you.
Any, Alison, yeah.
And I think just building on that, Julia, it's about how we therefore make this strategy deliverable, and a big part of that is actually how we take the public with us to improve their you know, their health and their well-being. So again, it's about one of the deliverables will need to be about how we communicate it, and again how we sort of embed it throughout the system, and make it a working document. So it's really important about it being how we deliver it. So, you know, the plan that comes out of it.
I agree with that really very strongly. I think you're absolutely right about that. And it strikes me that the way comms in the past related to public health has been, it's all about, seems to be delayed gratification, you know, and that won't work. I think it's all about the fact that if you look after yourself, you'll have a better quality of life now, because you know, changing one's diet, taking a bit more exercise, it doesn't take long for it to have a beneficial effect to your well-being and this, that, and the next thing. And for me, I think concentrating on that is more likely to get people on board than saying, you know, if you you know, you might not be dependent on the state in 30 years' time or something. That sort of analogy won't work. But it's all about the fact that it'll improve here and now. Does that make sense, Craig? Yeah.
Thanks, Chair. That absolutely makes sense. I think that's what we're striving to achieve. I just wanted, and I think this is probably a combination of me in denial about needing glasses and being a bit dyslexic, but the strategy is quite wordy, and I'm not sure the ambition makes sense with regard to inequality increase healthy life expectancy. That was all.
So you don't think the ambition sits particularly well with the strategy?
I think the ambition is sound. It is just quite wordy. And the ambition to reduce health inequality and inequality increase healthy life expectancy for all.
Sorry, Claire, you have to.
Sorry, yeah, I think there's a typo. So it says to reduce health inequity and inequality, being obviously slightly different things, and then there needs to be a comma or an and, so that's my error. The top paragraph, I suppose it's a little bit difficult out of context, but when it's, I guess what that's intended to do is within the sort of 9 or 10 page strategy, it's a summary of all of it in theory. So I can see on that slide on its own it might look a bit too much, but perhaps when you see it in context with the whole strategy, see if you think the same, and if so, you know, we can, obviously this is all subject to change and can be removed or tweaked as necessary. But it might make a bit more sense maybe once you see it in the full strategy, if that's helpful.
If people are agreed, in the light of what Alison and then I have raised, I think a comms piece about how we deliver this is important. Otherwise, we're at risk of saying, well, it's up to you guys, and they will say, well, it's not.
So, oh, I'm sorry, Tim.
I'm struggling a little bit at which point in the presentation to come in, because I don't know what's to follow, but it strikes me that what we haven't addressed so far, but we all know, is around the wider determinants of health. And I'm assuming that the strategy around promoting a collaborative approach means a broader partnership that deals with the socio and economic inequalities that we know contribute to poor health and inequalities in health, as well as those important issues around individual choice that we've heard about. So I'm assuming that we will be calling upon partners, including the county council, district councils and so forth, that our economic and other social strategies will also help to promote health in all and understand that wider partnership approach and change that we need to encourage in society to address these issues, rather than expecting individual change to achieve all of that without that supporting context. But I don't know quite what's coming next in the presentation, so I wasn't sure when to raise those issues.
Julia and I have been scratching our heads a little about how the public health agenda can work with the district and boroughs, because there is something eccentric about the fact that public health sits with us, but the wider determinants of health sits with the lower tier authority, and how we manage that. So your point is absolutely bang on, really, and it isn't just a question of saying people need to do more for themselves, because they clearly do, but we've got to get the comms right. But on the other hand, we've got to increase the possibility of them being able to do more for themselves, and that's where the wider determinants of health come in. Absolutely.
So Tim, if I keep going, and then if you want, we can come back to that point and you can see whether you think it reflects that fully, and if not, we can have a look at what we need to add or change. So in terms of the principles, again, this reflects a lot of the feedback that we had from board members and from sort of previous conversations. This will hopefully be a sort of a way of us kind of reflecting on how we take this forward. So when we're looking at developing those deliverables and those actions underneath the key priority areas and the areas of focus, looking back to these principles and sort of making sure that that informs everything that we do and the way we go about things. So as you look through these, it's really a question of, are these the right principles? Have we missed anything? Have we got too many? So I'll read a few out because I'm not sure everyone can read them. So we've got prioritising prevention and early intervention, engaging with communities and co-producing solutions, recognising the growing contribution and needs of voluntary organisations surrounding improving health and well-being, recognising diversity and responding to inequalities and inequities, commissioning and delivering high-quality services that provide excellent value for money to those who need them most, tailored to people's needs, communicate clearly, making sure that we're understood and that information is accessible to everyone, so thinking about the sort of health literacy agenda, but without using some of that jargon, I guess. Strengths-based, making the most of existing community assets and insight, improving health outcomes through a good understanding of data, improving care coordination and designing proactive models of care, seeking to ensure local people have access to the information and support they need to remain independent and stay well, and developing the wider health and care workforce and embracing digital solutions. So these, as I say, reflect some of the conversations that we've had, some of the things that have been identified through the JSNA and other work, subject to change, tweaking, scrapping, as the board sees fit, really. Shall I keep going? Oh, go on, Alison.
It was just a comment, really, which I think I really, I think the principles there are really, really good. And I think that the thing that sort of comes out for me from them is that there's some real strong enablers there that you're building into those principles and making sure we're using all those tools that we've got available to us, like public health management and all the prevention tools, again, communication in there about making sure that the public are informed, and digital. So yeah, I really like the fact that you've weaved in all those enablers as well.
No, fine, yeah, you.
Sorry, I couldn't tell if you were pointing to Julia.
Keep me quiet this time.
So this is really a summary of a proposed approach, I guess. So this, hopefully, Tim, kind of reflects back what you were saying previously. I've suggested that it can be guided by the King's Fund 4 pillars of population health, which aim to improve health outcomes, promote well-being, and reduce health inequalities across the population. we know that the NHS, local government, voluntary sector, all the organisations have a critical role, not just as providers of health and care and other services, but also as employers, as key players in their local economy, as anchor institutions in their communities. And we also know that these challenges can't be addressed by the health and care system, you know, and those sort of key public sector bodies alone. A much broader approach is needed that pays more attention to the wider determinants of health and the role of people and communities in that. So thinking about the sort of healthy environments and creating those conditions to keep people healthy and well. So that's what these 4 pillars represent. So the wider determinants, our own health behaviours and lifestyles, but accepting that that's only a very small part of what we need to do. And actually the most impactful piece will be how we make the environment and create those conditions and enable people to make healthier choices and live those healthier lifestyles. That reflects again in the places and communities in which we live. So also building into that our social networks and our relationships and how we make the most of those assets. And also working to sort of be integrated in everything that we do, so making sure we're coordinating and collaborating and breaking down those barriers, I guess, to sort of make those significant improvements. So that's a proposed approach or sort of framework within the strategy. I think Tim's indicated.
Tim, then me.
Very happy with those. That was just what I was looking for, so thank you for that. I do wonder whether it suggests that on the previous slide we need to look broader at our definition of communities to include employers and others who can make an impact in terms of the health of the people who engage with them. Thank you.
Again, very happy with what's there. I wonder whether under 3 it ought to explicitly say mental health and well-being, just so that that's front and central.
Under number 3, did you say? Okay.
That's perfectly feasible. Yeah. Yeah.
Thank you. I'll move on. So we come to the priorities. Again, reflecting the JSNA and what's kind of come out of that in terms of the key health and wellbeing concerns and sort of issues across the county. Also reflective of our conversations with board members, what they feel are the key issues for them and their organisations and their communities. These are the 4 that we're proposing. I think I need to change that to say reducing infant mortality, given that the others have got a sort of direction of travel in terms of aiming for healthy weight and healthy ageing, so it probably needs a bit of a tweak. So are these the right priorities? Have we missed anything? Are we happy with 4? I think there was a general consensus from everybody that we spoke to that we wanted to focus on fewer things, but do them well and have a sort of focused amount of effort in driving forward change. I'll move on in a second to sort of look at these in a little bit more detail in terms of areas of focus, I guess, for each of the priorities. So in terms of infant mortality, this would be around understanding and tackling the causes of infant mortality as a system to improve survival in babies up to 1 year. So that reflects the national definition of infant mortality. Key areas of focus could be a better understanding of data and demographic factors, reviewing of local recording systems and partnerships, enhancing that focus on smoking in pregnancy and smoking in the home, which we know is a key risk factor for infant mortality, ensuring accessible, tailored and targeted health and care, both in pregnancy and in the baby's first weeks, an enhanced focus on infant feeding, again, another sort of protective factor for reducing infant mortality, and having that whole systems approach to healthy weight in pregnancy. With this one in particular, I've had a couple of conversations with colleagues in the Children and Young People's Public Health team about whether it's the right place to have this in terms of the Health and Wellbeing Board strategy, purely because it features elsewhere in other partnership strategies, both in terms of the ICS and the Family Strategic Partnership. So again, it's a question, I think the result of those conversations were that everybody felt it was important to have it reflected within the Health and Wellbeing Board strategy, because it was a feature of the JSNA, and it may look sort of remiss not to have it in there, but whether there was a conversation to be had about where this kind of where the responsibility sits in terms of delivery against this as a priority, and whether that needed to be delegated, or sort of whether a partnership group is asked to deliver against that and feed back to the board.
Thanks, Chair. I'm conscious we've got, I think, quite a change in membership, I guess, since the Family Strategic Partnership Board was established, and I thought it was, at this point, I suppose, worth reminding ourselves that the Family Strategic Partnership Board is a subgroup of this board, so it isn't a separate partnership. It was established to deliver the children and young people's elements of the work that the Health and Wellbeing Board covered, and was set, and Phil sits on that board, and Mark and others around here, so it is part of this governance. It isn't separate. It just has delegated responsibility from this board to deliver its priorities relating to children and young people, and to report back, which we do 2 or 3 times a year on progress. This is also a priority for the Integrated Care System Children and Young People's work stream, which I am the SRO for, and is addressing much of the same issues. So I think it is trying to understand how the bits of the jigsaw fit together. I think it absolutely needs to be there, but I think it's about this board probably then holding the Family Strategic Partnership Board to account to deliver on this priority of report back, and then the ICS, we need to understand how we segue into that as well.
That makes perfect sense. So if they were to go on the work programme, the question is where in the work programme, in terms of the work they're doing, would be most appropriate for them to come and report to us. But before you answer that question, Mark, you want to come in?
Yeah, just very briefly, just to add to an extra layer, it's also a responsibility of the Early Years Advisory Board as well, which just adds to the sort of complex nature of the different boards and bodies trying to look at this area.
I think it's of such importance that we ought to hear from them, but I think to duplicate effort would just be counterproductive and wouldn't make any sense. Are you satisfied that the clinical and county and local authority expertise around the table will deliver?
If you'd have asked me that question probably 6 to 9 months ago, I would have been dubious. But actually we've really reinvigorated, particularly the ICS work stream, and we've got all the right people around the table to take it forward at the moment, certainly. And we report back as well through the West Midlands, through the Midlands NHS apparatus that sits around the ICS. We're also having a workshop, I think, facilitated by them very, very soon. But I do feel now we've got the right people engaged and that we can take it forward, Johnny.
Okay, and presumably they're looking at all the factors we've got down there. Yeah. Okay. So John, can we have that on the work programme when they will come to see us? We'll liaise with Helen to sort that out. Great, super, thank you. Any other thoughts? Progress.
Okay, thank you. So moving on to the next priority, good mental health. Again, I don't think this will be a particular surprise to anybody. I think almost everybody we spoke to mentioned this as a key priority for them in terms of their own organisation or insight that they themselves have gathered through their services or whatever. So this is about building good emotional health and well-being. So it's about that resilience to, sort of life's bumps and ups and downs, I guess. And happiness, and also preventing mental illness. So it's about, again, creating those conditions that promote social interaction. Physical activity, as we know, is hugely beneficial in terms of people's mental well-being. Thinking about the tools that exist already, like the 5 Ways to Wellbeing, which are just really simple, effective tools to structure a mental health, mental well-being programme. It's about supporting maternal and new parent mental health, and again that links back to the infant mortality agenda. That early identification and support for children and young people, workplace mental well-being, so again reflecting our roles as large employing organisations locally, but also how we embed that within other businesses, particularly those smaller businesses that might not have, you know, their own sort of occupational health and safety teams and things like that. It's about having that systemized, holistic approach to suicide prevention, which I think we have a really good sort of robust partnership in place at the moment, but it's building on that and taking that further. Tackling loneliness and isolation as a key issue, and particularly relevant where we're at in terms of the COVID-19 pandemic and the reports that we're getting of increased issues around isolation. Again, referencing that role as anchor organisations, and also capacity building, so encouraging communities to support each other and themselves, and how we do that through our existing networks, the voluntary sector, but also through things like the Community Champions programme, and really building on some of that.
Might I suggest we add another bullet point? These. I think, in fact, it's well recognised, and there's a lot of evidence to support the fact that, that social media, in particular, can be quite destructive to mental health, particularly children. And I think that there ought to be something about how we teach people to manage social media so that it doesn't get too much for them, how to use it, what to trust and what not to trust. And I've got some background in this, so I'm more than happy to help you with that. How does the board feel about that? Tim?
I'm grateful to you for raising that, because I was just trying to formulate in my head how to say it, and you've done it well. I just think there's a... Sorry. I'm grateful to you for raising that. It was an issue that I wanted to raise as well. I think there's a slightly wider piece too, where I perceive that over recent years we've become a more overtly critical and rude society, in as much as people seem very willing to discount other people's views and be unkind about how they do that as well. And I think there's a piece about how we all conduct ourselves and encourage other people to enter into reasonable debate rather than just being critical, that feeds into that concern around social media. But quite how we tackle that, I'm not sure.
I think we'll bear that in mind when we have when Claire and I have the discussion about it. But you're right. It's related, but it's a separate issue as well. Okay. Gary.
I think we might have a recurring theme here about where each of these priorities get picked up by other boards. This one, I don't think this is one where there's just a clear set of other boards. It needs a bit more thought, I think, going into it. Clearly the mental health work stream of the ICS, but I think there are things in this priority that board doesn't work on. So for each of these priority areas, we're going to need to map who's working on it already, aren't we, I think?
My view, and I'll take the other chair's view to see if you think the same. My view about this board is it's not here to do stuff, it's make sure stuff gets done. So therefore, we will have to go through all these bullet points of all the priorities, see where this lands, and be satisfied that it's being delivered. Would you agree with that? Okay, thank you.
I'm not used to this. Yeah, I would say yes, I agree, because this is about the strategy, isn't it? And this board is about ensuring that there's delivering the delivery, but not doing it. Yeah.
Thank you. Yeah, so absolutely, I think that's a piece of work that probably needs to, I think a lot of this is about, you know, the so what and what happens next. I think mapping that is probably useful. That will also hopefully then identify any gaps. So any of these that we think are areas of focus that aren't being picked up elsewhere, then we need to think about who's going to do that and how. I think the points around social media absolutely are valid. I suppose the question is, do we want that level of detail in the strategy, or do we feel that that's reflected in, for example, the top bullet point around, encouraging social interaction, and the 5 ways to wellbeing, which is about taking notice and things like that. And then the detail around a specific action around social media might come underneath that in terms of an action plan, but we can have a conversation about whether we think it needs to be included here specifically or not.
It's my view, it's such a massive issue. It doesn't need a bullet point on its own, but I think it needs to appear somewhere, so in the first one, that's fine.
Okay, thank you.
Thanks. Apologies, Di Markin, representing Staffordshire Police. Mental health is one of my portfolios within Force. Would there be an opportunity in relation to maybe a mentioning around self-harm or safety within that mental health slide? Because I know it's a big topic that we're working with both the council on in respect of the current confidential inquiry around safety within mental health, which covers specifically self-harm and what we're going to do. And I think if the wording's in there, it just recognises that it is supported by this board as well, the work that will be done by the suicide prevention agenda.
Well, Staffordshire and Stoke-on-Trent sees 10 suicides a month, which is far too high. Far too high. And that's not including those who try and fail. So we don't want to make this top heavy, but on the other hand, I think both the social media and the self-harm bit is worth mentioning.
I mean, it could absolutely go along. Sorry, I can't get the slide to go back. I don't know if the clicker's stopped working, Liam. But it could go along the same line of, the holistic approach to suicide prevention and self-harm. If we feel that it needs to be explicit, it is implicit, I think, within the suicide prevention line, because we know that's part of that action plan, isn't it, and the strategy. But if we feel it needs to be referenced explicitly, then yeah, it could fit nicely there, I think.
Yeah, I think, sorry, it's more talking about the safety element, which links in with the social media and that element of it.
Okay, I'll have a think about how we weave that in. Thank you. So moving on to healthy weight. So this is around tackling excess weight, both in adults and children, and again, creating those conditions to enable healthy choices. So very much about the environments within which we live, how we promote physical activity and active travel, how we ensure people have got access to healthy food options, but also making sure that that's equitable across the population. So thinking of a whole sort of family approach and a whole systems approach that looks at any policy drivers, any sort of planning decisions, anything at district and borough level, as well as those lifestyle choices and those support services that we might need at the sort of focused end of that sort of approach, I guess, in terms of those weight management services. But on the whole, it's about how we take that population approach to keeping people at a healthy weight and working with whole families to try and sort of get to that point, I suppose. And specifically, I've referenced within that the Better Health Staffordshire programme, which is on the agenda in a little bit, so I won't go into it in too much detail, but that's the piece of work that's kind of in its infancy, I guess, and is going to be a long-term commitment and a long-term piece of work across the county for any and all organisations and communities that can be involved in that. But because that's already starting to sort of gain momentum, I think that's probably a useful reference point within the strategy to sort of get that commitment from the board to get behind that piece of work.
We have Better Health Staffordshire approach coming later in the agenda. And that will flesh this out, I think. But I'm happy with this.
Liam, I think the clicker's stopped working. Would you mind? Thank you. And then lastly, healthy ageing. So this is about developing and maintaining functions and independence to enable well-being in older age. Again, a reflection of the JSNA data, but also feedback from colleagues around the board. So it's about how we promote and enable healthy lifestyles, so to keep people healthy as they grow older, to keep them independent and well, to prevent ill health, but also to prevent that subsequent demand on health and social care. Growing that strengths-based practice, that model within the health and care workforce who are supporting and working with older people. Thinking about how we ensure everyone as they grow older is in a warm home and ideally an energy efficient home, so making use of things like the Warm and Green Homes programme across the county. And I've already mentioned around promoting independence, but also around preventing falls. And also thinking about how we ensure people have got more choice at the end of their lives, so a focus on supporting people if they want to die at home. So that's not something we do particularly well at the moment in Staffordshire, so all of those things, thinking about how we just keep people independent and well and sort of prevent that subsequent demand on services.
Thoughts? Tim?
I think it's probably implicit within this, but I think we should say that we would wish to put in place the services and support to enable people to live in their own homes for as long as they are able to in their old age, so that we perhaps change how we deliver social and healthcare services to that end.
I think if we're not careful, we say we want people to take a strength-based approach when they're assessing and working with residents. But it's very hard to change the culture on the ground. And there is some evidence that actually it's not as strength-based as we would wish. So I think that I would like to see, in addition to this, if I may, not just growing the strengths-based approach, but looking for evidence that the strength-based approach is actually being used to good effect. I think it needs to be a bit of both there. Because coming from a profession where managing risk is what it's all about, taking a strength-based approach it puts the management of risk into more relief. It's allowing people to do stuff that we might think is against their better judgment, but they insist on doing it, and we should allow them to do it. It's those sort of things I think we need to be cognizant of and be mindful of, and I think it should be in there, or it'll end up just being a line that doesn't deliver. Okay. Richard.
Thanks, Chair. Yeah, I agree with your last point. I wonder as well about expanding the final bullet there to include sort of preparing people for old age and death, so it doesn't come as a surprise to people. Quite often people sort of seem to tip into services in extremis because of lack of preparation, both personally and professionally, and often outcomes are pretty poor as a result, and there's possibly more that could be done to help people to understand the likely trajectory towards the end of life and to make sure that that is properly planned for.
I think that's eminently reasonable. Eminently reasonable. Julia?
Yes, I very much support that. I think it's a part of life's planning that many people prefer to ignore, but is inevitable as being born. You know, we plan for birth to quite some extensive degrees nowadays compared with when I had children. But actually, most people prefer not to talk about it to their families, but it's inevitable. And the more you can plan, whether it's powers of attorney or whatever, it makes that transition less traumatic. And I think it's educating the public to feel more comfortable with old age and death, to be perfectly honest. So I think that's a very valid point.
Alison.
And just finally on that, and I can't remember if it was in the JSNA or whether it was at the beginning of this, the strategy presentation, but we talked about promoting and supporting management of long-term conditions and frailty. It's somehow building into that actually managing frailty is a long-term condition, so building into that the sort of prevention and the self-care and those those strategies of coping with frailty and helping carers to cope with that. As I say, I can't remember whether it was in the strategy bit or the JSNA, but I liked where you put that as a long-term condition.
Claire.
Thank you. Yeah, I can certainly reflect all those points.
Thank you.
That's it, I think, from me. So I think that's the last slide. Liam, would you just double check, please? Yeah. So from this point, I'm happy to take any further questions and feedback now, or I can circulate the Word version of the strategy, which contains that information and a little bit of wraparound text. And I guess when you've seen that in context, have a read through, see if you think it reflects everything we've talked about, obviously subject to the changes that we've discussed today. And then I can make that update, and if everybody's happy, then we can move that through to consultation.
Tim.
You made the very valid point earlier that this board is not about the doing, but ensuring that it is done. And I just wonder where in the strategy or associated documents we look at how this is going to be done and the partners that need to be engaged with it and the other strategies that need to be influenced by it to achieve the outcomes that we are looking at from this.
I think that's a very good point, and I would ask Claire and her colleagues to put against each bullet point which organisation we can call to account or expect to deliver, because that gives some meat on the bone, doesn't it? Definitely.
So, I mean, we could do that. I think for most of them, it's going to be a combination of organisations. So things like Better Health Staffordshire, for example, is a number of different organisations and whole systems, in fact, that are engaged in that piece of work. I guess as a starting point, I was going to suggest or ask the board whether they felt each priority needed a sponsor from the board to sort of set things off. And then from there, I think we probably need to do that sort of mapping exercise that Gary's referenced, and also then start to put a little bit of meat on the bones in terms of supporting actions underneath some of these and what those deliverables look like and how we measure success, I suppose, against some of these areas of focus as well. Some of that will include things that already exist, for example, through the Family Strategic Partnership Board, where there's already an action plan against infant mortality. Others will need a little bit of work. So that could be the next piece of work, certainly. I think we will need contribution and input from board members to do that. And I think that's going to be key, really, in making sure we get something meaningful out of the strategy.
Quite happy with that, but I do think within that piece of work we need to understand, albeit not just a single organisation, but who in the system, and the who can be plural or singular, is there to make sure this comes about, and then we can decide how best we're going to assure ourselves that this is delivering. Tim.
I don't want to labour the point, but I think there's something when we think of the sort of Marmot approach to these things where there's a whole system approach here, a change that needs to happen in community and a much wider engagement of all of the partners. And I think whilst we can only hold to account specific organisations or individuals, I feel there needs to be something in here that guides those people we're asking to look at these issues about that breadth of approach, because what we've sought to achieve so far it demonstrably hasn't worked overall, because we're still looking at the very embedded, complex, wicked issues that we've been looking at for many years. And we need to find some way of actually changing that. And I think it is probably more about bringing together those those much wider partnerships who engage the community as a whole on these issues that will result in that sort of change. Thank you.
I understand where you're coming from. And I'd like the view of the board on this. I see the next item, Better Health Staffordshire, which is the obesity item, which is a whole system place-based approach, not just as a worthwhile approach to tackling obesity in its own right, but a pilot to see how it works, and we can use that for other strategies. But in the meantime, I think we do need we do need to have organisations in the frame so we can challenge about what's being done. Okay. Claire, thank you. Are you clear as to the steer you've been given?
Yep.
Okay. Okay. We now go on to Better Health Staffordshire, and first I'd like to welcome and thank the Chief Executive, John Henderson, for coming, who's agreed to be a sponsor for this. And we're grateful for that. This is in large part because many of us feel this is such an important issue that we needed a high-profile individual to help sponsor it. And you and I are the co-sponsors, I believe. And Tony, welcome. And I understand there's a dietitian coming with us issues.
We've got someone who actually really understands these issues. She's remote, but she's joining us via Teams.
Hello.
Hello.
Lucy Marquis, is that right?
Lucy Marquis.
Marquis, pardon me.
Thank you.
Great to have you, thanks very much. And I believe you're one of the 2 dietitians from Midlands Partnership Foundation Trust who's part of the scheme, is that right?
I am, yes.
Great, thank you. John, you look perched as if you want to say a few words.
Thank you very much, Chair, and thank you very much for the opportunity to present to the Health and Wellbeing Board today. As you've kind of stolen many of my sandwiches to start with, which is that this is a whole systems approach, place-based approach, and I readily volunteered to take this on because I wanted to make the point this is actually about everything we do, but it is not a Staffordshire County Council programme, and witness the fact that Lucy is here today to talk about the dietary aspects of it. This is something where we all have a piece to play. I think that the last 18 months, 19 months now, or whatever it is, since March 2020, have really brought home one of the factors around obesity and its effect on public health. And I just, in preparing for this, looking up, discovering that you're something like 3 times more likely to end up in an intensive care unit if you're obese than if you're not, with all the other factors that are there. So that would probably be as good a reason as any to tackle this across systems, given that living with COVID is very much one of the focuses of all of our organisations, because this is going to be with us for some time to come. And indeed, we saw people like the Prime Minister himself mentioning the fact that the reason he ended up on oxygen was that he himself was overweight. So this is not, as I say, a Staffordshire County Council project. It's a long-running thing, and the 2 speakers today will give you some progress up to date, and then also, hopefully, we'll be grateful for your support as we go forward in this. So thank you very much for the opportunity to be here today.
Thanks, John.
Pleasure, thank you. Tony, over to you.
Great, thanks. You'll be delighted to learn that I'm going to whistle through a couple of slides really quickly and then hand over to Lucy, who will be much more engaging. What am I pointing? Are you all right to do the slides, Luke? Cheers. Great, thanks. Okay, so Better Health Staffordshire essentially is our brand name for the work that we're doing around obesity, which is very much about looking at physical activity and diet. And I think you've heard from Jude Taylor from Together Active once or twice in the past. And so we've got Lucy today to talk about the diet side of things. Better Health Staffordshire essentially is some short-term approaches to try and make an immediate impact, but also that long-term development. I think we recognise that we've tried initiatives before around obesity that haven't had the impact that we would want, And I think we've learnt lessons from other fields like smoking, where over a long period of sustained actions from a number of different parties, we are able to make some quite miraculous changes. I think in the 1980s, if we thought that only sort of 10-15% of adults were smoking compared with sort of 50% of adults in those days, we probably wouldn't have believed it. I think we've got a similar challenge with smoking. So we've tried to balance Better Health Staffordshire with doing something now and trying to make an impact to lessen the impact of the pandemic, whilst also developing that long-term approach. So I'll give a quick update and then hand over to Lucy. Cheers. So there's a number of things that we've been doing. The first category really is those sort of broad coverage, low impact areas where we're trying to reach a large number of people, albeit probably not having a massive individual impact. So we've done a number of campaigns. I'm going to put my glasses on and I can tell you the numbers. 171,214 people saw the first campaign on social media, and 557,764 saw through some of the digital advertising. So my basic maths off the top of my head suggests that's about 700,000 views, now not necessarily people, and that translated into about 7,000 people accessing the information that we provide. So I think, given what we spend on campaigns, which is very little on the digital campaigns, we've got some good reach out there. People are seeing the information that we're providing and people are accessing that information. We've got another campaign that's going to be starting in New Year. We've improved our EAG offer. There's lots more and better information on Staffordshire Connects, and we work in partnership with Together Active around the Active My Way online portal. There's been developments around the NHS online weight management tool, and we've got 97 out of 107 GP practices that are referring into that. We've purchased Orca, which is an online app finder. Apparently there are 360,000 health-related apps. Some of them are great, some of them are not so great. Orca helps to quality assure the apps that are out there and directs people to the most effective evidence-based apps. And we do a lot of advertising around that. And we're also doing a lot of MEC training, making every contact counts. There's good evidence for very brief interactions with health and social care professionals can have an impact on behaviour change. And there's a whole bunch of other things as well. I'm probably doing disservice to what the team's done, but I think the point I was trying to make there is that we're trying to hit a big number of people with some behaviour change messages. They're complemented with some lower coverage initiatives that hopefully have a higher direct impact. We've seen a real resurgence of the National Diabetes Prevention Programme, the NDPP. We've gone from one of the lowest performing areas to one of the best performing areas in the country. The Family Weight Management Service has been a big success this year. We did about 120% of the previous year's activity in the first 8 months of the year, and we're expanding that through to the end of the year. And the adult weight management programme, we did 3 times the number of interventions in the first 6 months this year as we did in the previous year. So we're really pushing the weight management programmes that we've got, and we're offering that through the workplace health offer as well. So a number of things that we probably aren't sustainable in the long term, but can have a direct impact while we develop the longer term programme.
For a second.
Sure.
The way you've described these describes the activity, not the outcomes. And at the end of the day, you can do a lot. We all do try and do a lot, but it's a question of how effective all these outcomes mean. Now, given COVID and all the rest of it, and we're just coming out of this, you may not have the outcome data to hand, but for the purposes of this committee, we're particularly interested in outcomes.
You're right. I do have one to hand. The NDPP, the average weight loss there was around 4.4 kilograms or 9 pounds. There are figures, I don't have them to hand, but I can share those with the group. So we with all the, or most of the programs that we commission, we look at the activity and then the conversion into a successful outcome. Certainly for the Everyone Health weight management program, we've got data on the average amount of weight that's been lost, so I can supply that to the committee.
I'd be interested in Lucy's view. I mean, if I lost 4.4 kilograms, I'd disappear. There's many of my fellow residents in Cannock, if they lost 4.4 kilograms, you wouldn't notice. And I just wonder whether there's other tools we might use to determine outcomes, like girth and abdominal circumference. I'll leave that to your professional view, Lucy, when you come and speak to us. Anyway.
There's only a couple more slides from me, so you'll be able to hear from Lucy very quickly. Are we okay to move on, Liam? The long-term approach is the whole system approach. It's a piece of work that Public Health England have devised, and we're following that process. Whole systems approach seems to be is one of the trendy terms, isn't it, at the moment? I think essentially it means us working in partnership and looking at how we impact on one another. It's a 6-stage process. We're on stage 3 now. We've been doing a lot of that, building the foundations, understanding the nature of the problem, understanding what one another does in this area, and we've started the workshops to bring partnerships together. If we just go to the next slide, you can see the timeline there for the 6 stages. We're in the middle of phase 3 at the moment. The action planning will start in Q1 next year. So it's a in some respects, it's a kind of a slow, gradual process to try and get this right. We've done things in the past where we've rushed this, and things have fallen down before they've really had a chance to have an impact. So that's very much why we've taken that twin track approach of developing this slowly and gradually whilst doing the initiatives that I talked about before to make sure that we're having an impact. Could we go to the next slide? We've had great support from partners. There's been a huge turnout at the workshops that we've done, lots of positive feedback. There's clearly an appetite, if we pardon the pun, to be involved in this. That wasn't planned, I promise. So we're really grateful for the support that partners have shown so far. And really the request from the board is just to continue that support in shaping and developing this. As John mentioned, this isn't a Staffordshire County Council piece of work. We're helping to get it off the ground. We've got a partnership group that representatives from a whole bunch of partners that are developing this. So we're really grateful for that, and we'd just like that support to continue. So unless anyone's got any questions, I'd suggest we move over to Lucy, who can give some insight from a dietitian's point of view.
Lucy, welcome. There was a feeling among some of us early in the stages of this program that we were concentrating, although exercise is great for you, and even if you don't lose any weight, it's still worthwhile doing, that we weren't concentrating enough on diet and what people put in their mouths. And we're grateful for you and your colleague joining us in this endeavour. And over to you. Thank you.
Thank you. We feel very lucky to be involved, and I'll speak on behalf of Lindsay, who's currently on maternity leave. I did send through some very last-minute slides, which I'm not sure whether people have got, but if not, is it possible for me to share my slides now? Thank you. Can you see that okay?
We can, thank you.
Lovely, thank you. So thank you first of all for Tony for inviting me to share my experience and hopefully demonstrate the fundamental need for a whole systems approach to obesity. My background, as Tony said, is that I'm a dietitian, so trained for the last 10 years in diabetes and obesity. Trained Stoke and Staffordshire at MPFT 3 years ago from Torbay Care Trust, and I wear a couple of hats as a dietitian. I'm also secretary for the British Dietetic Association Obesity Specialist Group, and Diabetes UK Clinical Champion. So what I'd like to do today is just share with you one story, but two different histories. So the medical history, and this is a lady that I met when I first joined MPFT, and I'd received a referral from one of the diabetes nurses, just sharing with me that she was stuck with this lady, and that she felt that she needed some dietetic support because she was struggling with making any dietary change. So a 45-year-old lady with a complex medical history. I'd reviewed some of her historical letters in preparation to meet with her, and just a few excerpts from the kind of medical history. So described by my colleague. So this lady had tried several diets, all of which had failed. She's unable to exercise at the moment and walks with a stick because of her back pain. She's also been consulted with a dietitian at length regarding the type of diet she should follow to achieve this weight loss that she needs. Other entries saying that she's not really made any dietary changes, suggested at her last appointment. We've again talked about the importance of portion control, general healthy eating, and trying to do some exercise. So she'd been kind of under the diabetes service since 2012. And again, a few excerpts there from what the kind of medical history that I had looked at, looking at portion control, acknowledging that there were very little changes made, and you can see there that her weight was fluctuating and lots of different medication was being used to attempt to help support manage her diabetes, but also in an attempt to support her to lose weight. So when I met Vicky in 2019, the first appointment that I would spend with anyone is a longer appointment to spend some time together exploring that person's story, what matters to them, and what had contributed to them gaining weight and living with obesity. So Vicky has bravely shared her story for the first time fully, and also has given me permission to share that with others to help support their learning about the complexity of obesity. So I'll just share that with you. So Vicky experienced emotional, physical abuse and neglect from being a baby from her mother. Vicky's mum lived with alcohol addiction, and her dad left. Between the ages of 7 to 10, she lived between her mum, nan's, and her dad's. Her dad was away a lot, but he left her some money for food, so she had around £10 a week. Vicky got a paper round to add to that money, and she used to use the money to buy sweets and what she describes as junk food and magazines. These made her feel better and gave her comfort when she felt lonely. At 16, Vicky met an older man and became pregnant. She had little support with her children, and she was embarrassed to breastfeed. Vicky worried that people would think she couldn't look after her baby if he was thin, so she made sure he had lots of extra milk and kept trying to feed him when he wouldn't feed. Vicky's partner was abusive physically and emotionally. He would call her fat, lazy, and stupid. Vicky described her years in this relationship as a dark time. At times, Vicky ate for comfort, but she also ate to maintain her weight because this made her feel safe. Vicky had 2 children with her partner, but he eventually left her to bring the 2 children up on her own. Vicky raised her children alone. She didn't drive, and she worried that she could not give them healthy food as it was not available in her local shops, and she struggled with money. Vicky developed diabetes at a young age. She had a part-time job, but she struggled to maintain her blood sugars during working hours as she was nervous to ask for breaks. She also worried that she'd have a low blood sugar on the bus and that people would think that she was drunk or taking drugs. so she would eat lots of sweet foods to make sure this didn't happen. Vicky's hugely proud of her children, and both of them have gone to college. Caring and nurturing is important to her, and she loves to show care for her children. And now that she has a little more money, she shows her love for them through meal times, cooking, baking. Positively, she's in a new relationship, but she lives separately. Living on her own, she worries that she will have a low blood sugar and fall. She's received counselling in the past for agoraphobia and 3 bereavements. In the recent weeks, when I saw her, she'd found out from her dad that her mum used to burn her with cigarettes when she was little. This has really upset her, and she struggles to think about it. When she thinks about it, she eats for comfort. Her son suffers from depression, and he self-harms at times. Last year, he made a suicide attempt, and Vicky worries constantly about him. When Vicky is on her own, she worries. This leads to a cycle of emotionally driven eating and self-criticism. At times, Vicky describes eating to cope. She explained that when she feels told off or judged, this happens more. Her mobility is poor, and she is terrified of falling and not being able to get up, or someone not being able to lift her. She worries if she has a hypo, as I said, that she would pass out, and that will happen. She worries about being told off at appointments for not losing weight and feels a failure most of the time. She was referred for bariatric surgery but became anxious about this, as she felt she can't always control her eating and thinks that the small stomach might rupture. She stopped going to appointments as she believes surgery is her only option and she would be forced to have it. So diet and eating behaviour evolves over time and is influenced by many factors that interact in a complex manner. So social structures, life experience, environment, locality, religion, traditions, seasons, psychology and cultural choices. And this is often overlooked in a health and care environment when professionals are seeking the right advice to give, and people living with obesity are desperate for the right advice to follow. Obesity is not a choice, and people become overweight or obese as a result of a complex combination of biological and psychosocial factors combined with environmental and the social influences. It's not simply down to an individual's lack of willpower, which lots of people carry around that feeling. Psychological experiences play a huge role, and up to half of adults attending specialist obesity service have experienced childhood adversity. The specialist service that I worked in, 50% of people that participated in the service used food to manage emotion. And just some stats on food insecurity and the impact that can have on the way that people grow up and their experience and relationship with food. So the Trussell Trust supplied more than 2.5 million 3-day emergency food parcels, an increase of 33% on the previous year in 2021. Around 40% of these went to children. 1 in 5 places to buy food are fast food outlets in the richest fifth of local authorities, compared to 1 in 3 in the poorest fifth. So Vicky shared at the end of consultation how much being listened to had meant to her, and how much having the opportunity to reflect on all of the aspects that have contributed to her weight. And what concerned me was that she hadn't had that opportunity, and she'd carried around this feeling that it was her personal responsibility and this lack of willpower. And I think I was hugely excited when myself and Lindsay were invited to join the working group for Better Health Staffordshire, because it feels like this is the start of some way of addressing some of the things that Vicky experienced through her lifetime. So thank you for listening, and that's just one experience that I've had working with someone, but Vicky's story is just one of many.
Lucy, thank you. I wonder if you go back to the slides and put up the one that's got the social determinants of being overweight, because I thought that was quite instructive. And give our thanks to Vicky for being happy to share her story with us.
I will, thank you.
Thank you. It is, however, the case that she is she's an extreme example of somebody who's morbidly obese and whose diabetes is off the scale at 75, I think. Notwithstanding that, there's aspects of it that certainly are instructive. And to my mind, this is the reason why it needs to take a whole system and place-based approach because of these social determinants. I'll open it to the floor for review. Well, I'll give you mine. No, Julia, you go first. Go.
Yes, thank you very much. I was thinking about that because it's almost as if there are different categories of obesity, and you're quite right, the one that Lucy's described to us is somebody who her problems manifest themselves as obesity, but actually they're probably classed more appropriately as long-standing mental health and social problems. And it's how we can tailor-make support to those people. It'd be interesting, Lucy, if actually, you know, Vicky had been able to make progress once somebody had taken the time to sit down with her and for her to be able to talk freely and in confidence. There's another part of the population that probably are not at that scale of obesity, but like many of us, me included, carry a few extra pounds, and each year that gets worse and worse. And the question I wanted to ask Tony, actually, is in terms of the workplace work that's being done. Because if you look at the proportion of the population that goes to school or college, which are a pretty captive audience, and perhaps Helen could elaborate as to what we may be doing in that arena, taking the population that is that goes to work, we've got two areas of fairly captive populations. What are we doing working with employers? And perhaps the biggest one is the NHS, and most of us, if you go into a hospital, they've certainly got some opportunities to support their staff to eat more healthily. Having worked within hospitals over the years and being able to grab a quick snack, and that's about it. There's probably some better employee-employer practices there. So I appreciate Lucy's given us a detail of, as you quite rightly say, somebody at the far end of the scale. But what are we doing with those people who it would be really beneficial to them now and in the future to lose some weight, to change that lifestyle, but within the workplace and with the educational place? Because I think those are two areas where we could actually deliver some, or help to deliver some improvements.
I agree. I remember being a boy and the Stop Smoking campaign came round to school, and I've still got a vision of a lung, a pathologist lung with a cancer in the apex of the lung. So you're quite right. And people would go home. My wife went home and took the cigarette out of my father-in-law's mouth. Tony.
I'm a child of the 80s, and I'm still traumatized by the AIDS adverts of the 80s. If people remember the monolith taken from the Stanley Kubrick film. So yeah, these things have a lasting impact on us, don't they? But to answer Julia's question, yeah, workplace is an ideal opportunity, I think, to engage people. We've developed a program this year that enables people to access the more intensive weight management services that we've got through the Everyone Health contract. We haven't had a huge take-up at the moment. I think whilst we recognise health as a key priority, I think a lot of businesses are struggling with recruitment and supply chain issues. We've not had the buy-in yet that I think we anticipate in the long term. So I think there's a real challenge to try and get those businesses to sign up to the scheme, because they will have access to really intensive interventions that would be more difficult to access otherwise.
I'm sure you do, but it's worthwhile saying to businesses that actually, if you have a healthy workforce, it'll be a more productive workforce.
Yeah, obviously we're not going to give up on the programme because of a slow start, but absolutely.
Yes, you've made the point that I made, that actually, you know, it does have a benefit to them in terms of a more productive workforce. We've created and have a very proactive group called SBEN, which employers who are adopting and very keen and enthusiastic about the green agenda. I just wonder whether we could replicate that kind of networking, of support with businesses to businesses for that healthy agenda, because again, there are companies now who are beginning to realise that there are economic, apart from ethical, benefits to having a green agenda and looking at all their processes and practices. I wonder if we could replicate that with a health agenda. I think that would be really quite exciting.
I agree. Yeah, Mark?
Yeah, I mean, this is quite interesting, and you put the slide up about the social determinants, and as members will around the room will know, there's weight measurement of children in two years in primary school, and they are not they're not good reading really. But what I would point out that you know, if you look at that and it's divided up between the different areas, districts, boroughs of the county, it does not necessarily follow that the worst areas are the ones where you would expect them to be the worst because of social determinants. You know, and if you look at the figures for South Staffordshire, that is probably either the top or the or top or second most affluent area in Staffordshire, and it's got one of the very worst levels of obesity in children. So I think that's just food for thought, that it doesn't always necessarily follow those social determinants up there.
There's a statistic, if I recall, whereby those this was some time ago now, the most deprived areas, in adults, there was 50% of those who were overweight or obese. The least deprived areas, this was in England, it was 15. So there is a difference, but 15% is still far too many. I take your point for Staffordshire. I think it's really quite interesting. Tim.
And yes, part of the remarks I was going to make was to say actually the statistics that I've seen do support that it is the more deprived areas that more consistently have people with poorer health outcomes, including obesity. I very much support this whole system approach and broader way of addressing it, and I certainly feel more comfortable with it than the kind of big fat chat approach that we've looked at before. What it won't do, of course, is wholly address the social determinants that we've got up on the screen in front of us, and so I'm struggling a little bit in my mind to see how we can take that whole systems approach without being able to do that. So how are we going to kind of compensate for those families and communities who will suffer those social determinants more than the more affluent communities in how we take this programme forward? Because the disadvantages that people have are still going to be there that lead them to obesity. So I don't know whether that sort of thinking has been done.
Johnny.
Lucy will probably have a much more articulate answer than I, but my background's in drugs and alcohol and addiction, and I think there's some learning that we take across that behaviour and behaviour change is complex, and behaviour is it's never linear. There's never one factor that leads to another factor that leads to another. It's usually a confluence of issues that come together to create a negative, or a confluence of positive things that come together to create a positive behaviour change. And obviously we're not going to be able to change some of the socio-economic situations that people and families find themselves in. But through the whole system approach, we can pool our resources and try and find collective solutions in the way that we've done in the drug and alcohol world for the last 20 years with addiction services working with health and care and criminal justice agencies to try and find sort of bespoke solutions to people where we can. And I think the whole system approach gives us that opportunity. At the moment, through the workshops that we've had so far, I've heard lots of anecdotes of activities that one agency is doing and pleas for other agencies to do something slightly different because it interferes with the progress that they're trying to make. Because we've never had that sort of strategic approach before. Each agency's worked in isolation largely. So I think that the whole system approach gives us that opportunity to kind of pool our resources, pool our understanding, and make sure that we're not impeding one another from making the progress that we're looking for. And hopefully that won't contradict the expert view that Lucy might give.
My response to you is I agree with you in large part, and this is going to be more difficult than the smoking agenda, by quite some margin, I think.
Come back very briefly. I think there are some similarities to the smoking agenda in terms of individuals' experience, in the sense that with smoking, I think what we found is that people quite often need to practice giving up smoking. And I think in some similar ways, people need support to try different approaches to weight. So that's one issue there. But I do think that we need to influence the direction of our much broader socio and economic strategies and services to address those social determinants if we're going to make a real long-lasting effect to people, to health inequalities more broadly and obesity specifically. So yes, a targeted but broad-based approach to weight loss is really a positive step, but we're going to have to influence much broader approaches to how we run things in the broader county that takes into account those socioeconomic issues.
And that's, in my view, why this is a whole system approach. Helen, then I'll go back to Lucy and then close.
Just to endorse and echo really Tim's points, absolutely, because we're sat here talking about a symptom, aren't we, not root cause, and we could be talking about many, many other things, and it's the same social determinants that arrive there. It's how it displays, and it is really tricky not to crack, because we've been able to do that. The world would be in a much better place. I think some of us have been trying to do it for a long time. What I do wonder, in terms of, I guess, Vicky's story, which started in her childhood, and with the progress we've made, I guess, in recent years, through things like trauma-informed schools, which we have a number of across Staffordshire and which we're trying to roll out, which links obviously to things like children's social care, which I'm responsible for, but not exclusively. But training schools to spot the signs of trauma or something happening, something going wrong in someone's life, and working directly with those young people to manage that so that they manage it into adulthood. And I do wonder if it's worth looking at that, Tony, around the kind of implications for weight gain on that, because a lot of it is very focused on mental health, which is linked. But I do wonder, it is being rolled out at the moment. We've had to pause because of COVID, but for example, schools in Tamworth are now trauma-informed schools, particularly secondary schools. So I do wonder if it's something more explicit we could weave into that work.
Yeah, I think trauma is at the root of an awful lot of issues that we find. So yeah, I'd suspect that it manifests here in the way it does in drugs and alcohol and mental health and other areas. But perhaps hand over to Lucy, who would probably give a more professional view.
Lucy, I'm grateful for your views on what's been discussed, but before we do, I would like your view as to how do we measure success at an individual level and at a population level. Now, I'll tempt fate by telling you what I think it is, and you tell me whether I'm right or not. But at a population level, BMI is a reasonable way to go, but it doesn't work so well at an individual level. and perhaps we should be looking at girth or girth-chest ratio or something like that. Over to you.
So, in Canada, who are kind of far in front of us in terms of supporting people living with obesity, there are whole assessments and staging tools to measure impact of obesity and weight. So not just looking at BMI and weight and girth, but also looking at the implications on how people function, the impact that their weight may have on their ability to work and contribute to society. So I don't think it should just be weight and a waist measurement. It needs to be also a comprehensive look at the impact that weight loss is having on a person's life. To pick up on the last comment around trauma, in probably in the last 5 years or so, a lot of weight management, specialist weight management services starting to take a more trauma-informed approach. So that's really encouraging to hear. And from the comments around how we manage to address all of the social determinants and their impact on obesity, I think what's encouraging with the Better Health Staffordshire or the whole systems approach is just that acknowledgement at the moment that obesity is complex, and rather than feeling that bringing in a dietitian and telling someone how they should or shouldn't be eating is going to be the magic wand in supporting someone to lose weight is not the issue. So, just looking at Vicky's story around aspects such as breastfeeding and the impact on obesity, as we've mentioned, trauma and childhood experience on eating behaviour. I think it just kind of having the possibility of considering all of these aspects and people raising the awareness that these things have an impact, particularly for the person living with obesity, who is carrying around this sense of personal responsibility. And I know you've mentioned that this is an extreme case, but if you think that 50% of people are living with obesity and over 50% are living with overweight, I think we do need to be considering things from kind of childhood and parenting skills and all of those aspects as well that are going to avoid people gaining weight in the first place. Yep.
I concur with that, certainly. I think we'd all be grateful. I certainly would if you'd ping over the Canadian approach. That'd be really helpful. Yes, will do. And Lucy, thank you for your time. Thank you for the presentation. Once again, thank Vicky for the courage to be able to allow you to do that, because that's not easy.
No, not at all. Thank you. I will do.
Thank you.
Thank you.
Thank you. I've let that overrun. Apologies for those for whom that presents a difficulty, but I just think it was so important we had to give that an airing. Tony, have you got some brief now as to where, in terms of direction of travel and all
that? The next stage is we're operating the workshops at the moment that is bringing the partners together to understand what they want to get from this, looking at what the barriers are at the moment. The partnerships will start to form at a district and borough level in the new year to develop action plans with the view to the action stage starting at the beginning of 22-23, so Q1 next year. So, as I say, a slow, gradual build-up to try and get this right, whilst we do the short-term interventions at the same time to make sure that we are having an impact on obesity as we speak. As I said earlier, partners have been really supportive of those workshops, and the plea really is just to continue that support through to the next stage and to be part of the action delivering partnerships from Q1 next year.
Tony, thank you.
Thanks.
I'd now like to move on to item 5, Air Aware Staffordshire. Mike Culvery. Thank you and welcome.
Afternoon all. I'm quite happy to get you back on track time-wise, Johnny. I just wanted to bring to the attention of Airware Phase 2 to the Health and Wellbeing Board. We came to the Health and Wellbeing Board with Phase 1 a couple of times to update on progress. Then we had a year where we were just trying to keep things ticking over. But we were successful in another bid to DEFRA where we got almost £300,000 over 2 years split across the 5 elements that are detailed in the short report. There was also some additional public health funding that has gone into this that helped secure this funding in terms of match funding. Now the Airware project engagement supports Staff's County Council's Climate Change Action Plan. Kath Stevenson and her team, and it would have been Kath that would have been here today, will provide a more detailed presentation at the March Health and Wellbeing Board, because they'll have 2 quarters of data across the 5 elements, so the schools, business engagement, etc. So there will be more to come. Next slide. I won't spend too much going through the slides, only in terms of that obviously transport is the highest contributor to air pollution, and this is one of the things that you're working with schools and businesses. And the one thing that we did notice, which is on a further slide, is that during lockdown, across the diffusion sites for monitoring air quality, how much air quality improved in those located sites that we were doing in schools. So Staffordshire has 16 air quality management areas across the county. Phase 1, which was 2018 to 20, included Stoke-on-Trent, and Phase 2, which was sort of late summer 21 and go on for 2 years, aims to raise awareness county-wide, but with increased target engagement in Burton, Leek, and Cannock. Next slide. Business engagement. During Phase 1, the van that we had was a guzzling diesel. We've now got the EV, which is an electric vehicle. Obviously, very early days. It's been leased in a partnership with Amy. Mark Stanway is the business engagement officer, and he's targeting businesses in Burton, Cannock, and Leek across the air quality management areas to encourage active and sustainable travel, and to work and support fleet sites and improvements for charging points, hybrid working, car sharing, cycle training, and things like that. A lot of work going into anti-idling, and that's across schools as well as the business arena. The next slide, it's just some very early data. I'll just leave it there for you to... Now, I didn't see that's happening on my presentation. That's the cool bit of kit for recharging EV. Impressive, eh? Next slide. School engagement. There are 38 schools that are in the vicinity of air quality management areas. School travel advisor Ryan Proctor worked with 17 Staffordshire schools in Phase 1, and the remaining 21 are on target to be engaged during Phase 2. And one of the schools that we've been working with for 2 years on the trot is a regional school of the year, won by Heath Hayes Primary for their work increasing active and sustainable travel. As said, you'll get a lot more information in terms of outcomes and some of the work that's been going on in these in the schools targeted. The next one, well, the next two slides really, it was just the accumulation of data across 3 schools recording air quality. And you just go on to the next one, Charlie. You can just see the drop-off during lockdown when people were staying at home or making alternative arrangements. So we've got diffusion tubes in a number of the schools that have been participating. So at least during COVID, it still allowed for data to be collected over a long period of time without the school run contributing to that pollution. So it just shows you the pollution that is created during that school run. Next slide. Airware next steps. Well, March 22 will be the anti-idling campaign to make Staffordshire sustainable climate change activities. There's Active Travel Month as well, and also in June, Clean Air Day. And over the next year and 3 quarters that we'll have left with this project, we'll obviously be working with schools, businesses, and EV engagement throughout the remaining of this year, the year after, and into 23-24 as well. So, as I said, it was just to bring to the Health and Wellbeing's attention that we got this project funding continuation from DEFRA, and we'll come back in March and provide a detailed report across the 5 elements of the project.
Thank you, Mike. Given the fact you're coming back in March, I would like to keep this brief. Does anybody have any questions? I've got one observation. I've got 2 observations rather than questions. The first is that Heath Hayes Primary School is helped hugely by its geography. And I think one needs to bear that in mind. Parking on the road is a nightmare, and they use the car park in the local park just across the road. So they have been helped by their location.
Yeah.
The other point I want to make is you mentioned that there's 390 deaths a year due to air pollution in Staffordshire. And then when it comes to the economic benefits, you've got the additions. And I think one of the additions should be the effect it has on the quality of people's life due to ill health, and the burden it poses on the NHS and particularly adult social care. I mean, how long has somebody, one of those 390, suffered with quite debilitating chronic obstructive pulmonary disease and required our help? And if we sorted this out, that would reduce the impact and give them a far better quality of life. So I think you need to add that to the additions. But I thought it was a good report. Thank you.
Thank you, Johnny.
Anybody else? Okay. Tracy, you're not with us in person. Are you with us?
No,
it's Peter.
It would be me today.
Hi, Peter. Welcome. For those of you who don't know, Peter Axon is the CEO of Northern Combined Mental Health Trust, and now the interim chief exec of the Integrated Care System. Welcome.
Indeed, thank you. So, and that the commencement of that second job was, in fact, yesterday. So, so be kind, if it's all possible. So thank you, folks, for enabling this agenda item today. So I am conscious also of time, as per the last speaker. So I will try and get through it as quickly as possible. The first few slides are probably things that you are largely familiar with. So Liam, if we could head to the 4th or 5th slide, which references the ICS establishment timeline. Next, yes, that's the one. I'll talk a little bit about that and take it from there. So we're effectively in the business end of the development of the integrated care system. As you can see there, Q4, which we're rapidly heading towards and into, has a lot of the detailed activities within it that we need to do to legally establish the ICS on the 1st of April. I would perhaps momentarily add that, as many of you will be aware, there's been reference within the HSJ about potential delay to the ICS's establishment. For the purpose of the conversation today and all of the activities and exercises that are happening behind the scenes, we're essentially ignoring that and continuing on the basis of a 1st of April establishment. I understand that a go, no-go decision will be made by the centre in January regarding the timelines, but as I say, at the moment we are assuming that a 1st of April date is what we will be expected to deliver. If we could pop forward to the next slide, please. So again, people will hopefully be familiar with this. So this includes an array of key terminology, including aspirational priorities of the system as it stands at the moment, our purpose and vision that was developed recently within one of our workshops, and of course the 4 key priorities that an ICS is required to address and tackle in the middle there. Next slide, please, Liam. So very briefly, but really quite importantly, these are the functions and duties, so the core duties of the ICS that the ICS will be expected to deliver as of the 1st of April. There are a few additions, meaningful, although there aren't that many, they are individually very meaningful to the ICS's responsibilities beyond those of the CCGs that exist at the moment. So a key one of those, for example, is specialist commissioning services that will move from a regional footprint through to the ICS, and there are 1 or 2 other duties as well. So as well as the fundamental motivation behind an ICS in terms of integrated service and oversight, the core functional duties of the ICS will be different as well when compared to CCGs. Next slide, please, Liam. So this slide and the next few slides describe probably the relatively new stuff that perhaps the Health and Wellbeing Board hasn't previously seen or debated. So this slide specifically refers to the proposed composition of the ICB specifically. So that's the Integrated Care Board, the legally required board to oversee the delivery of the strategy for the integrated care system. And as you can see, there are certain aspects within it that are, as we describe in that middle column, required by legislation, and then certain aspects that are mandated by NHS England and NHS Improvement. And then beyond those mandated elements, there's a certain level of flexibility. But of course, within that level of flexibility, we need to consider key things like voting arrangements and you know, fundamentally, what's fundamentally required in terms of good governance. So that consultation closed as of yesterday. We're in the process of collating all of the views that have come from that consultation exercise that was largely led over the last month by Prem Singh, the system chair, with a view then to submit the proposed consultation, the proposed composition post that consultation exercise on Friday. There is an allowance to create a further iteration of that into the new year, so it's not the absolutely final version that we're required to submit on Friday, but it is expected that it will be very close, if not the final version. Okay, if we could go to the next slide, please, Liam. So this is just a bullet point representation, really, of the key milestones that we've either achieved to date. So you can see my name is there as the 3rd bullet point, or other things that we're in the process of doing in the background. So you can see in the 4th bullet point there, the non-executive appointments are in process. The adverts are out, and we expect to appoint to those in January. And in turn, we also hope to appoint to the executive director posts during Q4, with those adverts hopefully going out in January. So the personnel side of things is also heating up now. However, it's quite likely that we won't have the full board created and in place until well into Q4 and perhaps beyond that, which is simply the reality of the timeline that we're dealing with, I'm afraid. If we can go to the next slide, which I think is the last one. So this slide describes what for me are kind of 4 key next steps associated with the creation of the ICB. So the CCG due diligence and close down exercise is essentially the send process, which is doing quite technical but fundamental things like closing ledgers down and ensuring that all of the activities that need to be closed down are closed down in a safe, effective and legal way. There's of course the next step, which is the receive activities, which is the establishment of the legal entity to be able to take on board those responsibilities. So they're 2 key, quite technical exercises. Beyond that, there's the management of winter and the management of the elective long wait agenda and all things associated with ensuring that operationally we deliver an effective winter, as well as doing the technical bits behind the scenes on the ICS. And then the 4th key element for me as we go through the next quarter is ensuring that the transformation agenda associated with the ICS lands effectively, whether that be the development of the ICP, the development of the strategy that is part and parcel of that ICP, and the subtleties associated with the ICB and delivery through partners. So for me, those are the 4 key building blocks of the development phase, this next development phase over 4 or 5 key months ahead of us. I think that's the end of the slide pack, Liam. Could you just go forward one? Yes. So I did say I'd be as quick as I could, Chair. Happy to take any questions or comments.
Any questions? I've got a couple, if I may.
Yeah.
We note that we will not have submitted to us any commissioning intentions this year because of the reorganisation. And I think that, because I've been through a few changes in the NHS in my time, as many people in this room have as well, and it becomes inward looking. Now, commissioning intentions are a statutory obligation of this board. And you must have some intentions. You must be commissioning something. And to my mind, I think we ought to see it. And I don't think that this change should get away from business as usual. And it just strikes me to say that there's no commissioning intentions for us to see is part of the inward-looking nature of another change in which the NHS manages itself. So for me, I'd be grateful if you were able to offer us what the commissioning intentions look like for 22-23, particularly in the light of the pandemic. The commissioning intentions are more important than ever, and they must be somewhere, because somebody's commissioning something, and therefore we would like to see it.
Yeah, well, Chair, I wholeheartedly agree. I'm not entirely sure where that that description has come from, that we don't there isn't an intention to create commissioning intentions. It makes absolute sense that you described there the need to define what it is we will be delivering and doing in 22-23. And there'll be an element of roll-on from 21-22, of course, in terms of core contracts and core services, but there'll be a set number of extraordinary items in 22-23 that we have to deliver and appropriately so. For example, where we end up at the end of this year on our long waiters, our 104-week waiters, and what that therefore means for the 22-23 period is one example of that. So I'm a little baffled, if I'm honest, as to where that lack of intention has come from, but that's not my intention.
Alison may be able to enlighten.
Hopefully I'll be able to. Hopefully I will be able to. I mean, we aren't required to produce commissioning intentions as such now. We've moved much further along towards system planning. So we're actually submitting system plans, and just in the process of, in fact, I've just submitted what's called the H2 plan. So that's the second half of this year plan, which is really addressing, as Peter's just said, areas such as those long sort of waiters or long patients who are waiting a long time for operations, and how we're going to address the backlog as a result of COVID. So it's now much more about system planning and submitting those system plans, which moves us towards a new way of working as a system going forward as an integrated care board, rather than just commissioning intentions from the CCGs.
Okay, so I understand that. That makes sense because we're trying to get away from the purchaser-provider split and all the rest of it, and have a board that has both in it. But notwithstanding that, we as a board, as I'm sure you understand, need to fulfil our statutory obligations. So perhaps we should be looking at this system plan. Richard?
Yes, so presumably the duties of health and wellbeing boards will be updated in the legislation, because Alison's quite right. We have a statutory duty to consider something that will no longer exist, which creates a bit of an issue. There will be something for us about making sure that the health and wellbeing strategy that we considered earlier is reflected in the integrated care strategy. So they need to be complementary, but avoid duplication and contradiction. And also that integrated care strategy, which I see as focusing much more on health and care services rather than the wider determinants, that we are comfortable with the general direction of travel there. So I suspect it is that will replace the CCG commissioning intentions. And I think there's a suggestion that at least an early draft might be available at some point between January and March. So that might give us an opportunity to do so.
I understand. Go on, Alison.
John, if I just can come back on, just building on what Richard just said. So again, as the integrated care partnerships developed, which is the, which will be the sort of joint collaboration and committee between the integrated care board, which Peter is the CEO of, and the local authorities, the two local authorities, they will have a statutory duty to produce the integrated care strategy, which will then need to be delivered by the integrated care board. And it's really important that the part of that that will inform that will be very much produced, taken into consideration both health and wellbeing board strategies from Staffordshire and Stoke-on-Trent, and also the JSNAs from both those areas as well. So that's very much going to be a system strategy, which is statutorily the integrated care partnership will be responsible for. But as Richard says, that will be probably towards the end of the next quarter. So as we move towards, as that's set up, the ICP is set up in shadow form. That will be one of the first things that they will look to produce.
Thank you.
I hope that was all right, Peter.
I do think it's incumbent upon us to see that and to take a look at it and be satisfied that it's.
And I think all the processes and where that reporting and the relationships between the health and wellbeing boards and the integrated care partnerships will all become clear.
Thank you, Julia.
Well, I thank you for that last comment, because I'm sitting here thinking that's about as clear as mud. I think that's one of the things that I'm sure it will emerge, but how the relationships between the integrated care system and health and wellbeing boards will manifest itself in a few times, because I think what I'm anxious to be clear about is that they complement rather than duplicate. And I think whenever one of the partners changes significantly, and your role of the integrated care system is quite different, that actually a health and wellbeing board, which has a statutory function, that is still seen as relevant and can actually deliver. And the key phrase I always say to myself, make a difference. If it doesn't make a difference, I, for one, will start be asking, do we need to do things differently? Because I think we all give time and effort to these partnership boards, but they have to make a difference.
So we look forward to it in March or in the summer. Thank you. Can I now go on to item 7? And I'm sorry for the delay. This is from Helen Jones. John Wood, welcome. Helen, welcome. And Ruth, welcome. Over to you.
Thank you, Chair. Thank you, Chair. And I am conscious of time and will swiftly go through the overview paper, if that's okay. As you know, the Safeguarding Adult Board is statutory. We're concerned with those adults with care and support needs, either experiencing or at risk of abuse and neglect, and as a result of their care needs, are unable to protect themselves from the risk of either abuse or neglect. So that puts those adults who we're concerned with as the most vulnerable members of our communities. The annual report, which you'll see there, is 43 pages long, and I'll just summarise some of the core points from the report. Of those reports of abuse, and we have something like 12,000, and the numbers have actually gone up this year because of recording practice changes. But of those 12,000 concerns, there's something like a quarter will meet the duty of inquiry requirement. And of those, it's something like 50% of people will be aged 75 or over. And the sort of primary support need they have will usually be linked in some way to their physical mobility. So the people who are most at risk are, or should say, the perpetrators of the abuse and neglect are usually known to the adult, and they are usually people they ought to be able to rely on, either a relative or a carer or somebody in that sort of relationship, and that relationship is abused. So that's the sort of context of what our work has been about. The report goes up to the end of March 2021, and as you would expect, the work has been affected in large part by COVID. Some of those opportunities for natural surveillance of abuse and neglect have been taken away, so there's been new ways of working, particularly on practitioners, and new ways as well for the Safeguarding Board to continue its business. And you will see from the annual report that there's a lot of detail in there about a lot of work that's been done and a lot of assurances that have been sought and given in relation to the work that's actually continued. But we're not complacent, because we know that a lot of this work is hidden, or a lot of this abuse is hidden, and we need to constantly be vigilant, and we look for different ways of bringing out this abuse and neglect. But I would say to you that it is encouraging in one sense that we've had 12,000 concerns reported. The job then, of course, is to understand what lies behind those concerns and to ensure that those people who need that help and support are actually given that, and any harm is mitigated. I did say keep it brief. I'm going to stop there, Chair. Happy to take any questions for either Helen or Ruth or myself from the Health and Wellbeing Board. Thank you.
I just want to make a comment, really. It's a mammoth task you've got. If my memory serves me, there's been a 63% increase in referrals from 2016 to 19, and that's broadly the case across the whole of the nation. And I know that there's systems in place in order to address that. And I'm grateful for all the work that you do. I think it's a very difficult and challenging job. Any questions? Go on, Richard.
Not a question, Chair, but just to thank John, Ruth and colleagues for all the work that is done. There is a huge amount of work and effort that goes on, and particularly to thank John for his ongoing role as Chair for overseeing that and making sure that everything is done properly and in good order. So thank you.
Hear, seconded.
Can I just make a comment? And I would want to sit and acknowledge Ruth's contribution to a lot of this work. She clearly takes on a very significant role within safeguarding within the County Council. I think it's only right to just acknowledge that. And particularly some of the work that will go on for next year, we are very receptive to sort of feedback as to what we ought to include in this annual report, and already we've had some feedback which will allow us to focus on that. It really is important that people come back to us with any comments on things that we can do to help, because we are all in this together in the sense that our job is to keep people safe, and I know that's a view that's shared by the Health and Wellbeing Board too, so thank you.
So if anybody has any thoughts or comments to make on the report, send them to me and I'll forward them to John and to Ruth. Yeah. Thank you. And apologies for the delay. The forward plan. John, do you want to read out the forward plan and all?
Yeah, there's only a couple of things on it at the moment. I think we'll try and keep it short, like we've tried to move towards. Clearly, I think the strategy will be on the next agenda, and the frailty strategy, which will actually link in with the strategy as one of those kind of key priority areas as well. If there's other items, would members please let me know what they want to bring, what to raise at the next meeting.
I come to another statutory bit again. I noticed, this is on page 93, this is, that the pharmaceutical needs assessment needs to be done every 3 years, and it was last done in 2018. So, and I fully understand the whole COVID piece, but it is a statutory requirement of this board, and I just wonder when we might see it.
I know it's on the radar for next year, so it will happen. I will check, and if we can bring it to March or June.
Thank you. Much appreciated. Any other business? I'm grateful. The date of the next meeting is on Thursday, the 3rd of March at 3 p.m. And I look forward to seeing you then, and I hope more of us are in a position to meet in person come March. Thank you all. Bye-bye.